A very good day to everyone. My name is Dr. Rajeentheran Suntheralingam. I'm the consultant urologist. Today in the Malaysian Urological conference, 26 November 2017, I'll be debating on the arguments against radical treatment in oligometastatic prostate cancer. The debate is directed towards radical treatment in oligometastatic disease, not primary treatment of the primary tumor. Now, first of all, we have to talk, what do you mean by oligometastatic disease? Oligometastatic disease means the metastasis or the spread is very low in number, oligo, okay? But currently there is a variable definitions of what is meant by oligometastatic disease. There's no proper definition. Some propose 3 or fewer lesions, and the other propose 5 or fewer lesions. Now, oligometastatic disease actually requires that the lesion be amenable to metastatic directed therapy. That means we either radiate that metastatic disease or we do a surgical resection of the metastatic disease. So my debate is today, at the current moment, there is no role for radical treatment of oligometastatic disease, either by radiotherapy or by surgical resection. Now let's go one step back. Okay, this is exactly what is the continuum, the whole natural history of prostate cancer. At one time we talk about localized disease, locally advanced disease, and metastatic disease, like what is shown in this diagram here. Non-metastatic and metastatic, very simple definition, very simple classification. But now things have gone in more detail. Trials have come out. There are many different drugs that can be used in different parts of the continuum of the prostate cancer process. Now if you look here, now we talk about not only metastatic disease, we talk about metastatic hormone sensitive or castrate sensitive prostate cancer. We talk about metastatic castrate resistant prostate cancer. Among the group of metastatic castrate resistant prostate cancer, we talk about asymptomatic, we talk about mildly symptomatic, and we talk about higher volume metastatic castrate resistant prostate cancer. And then we talk about post chemotherapy or post oxytocin failure metastatic castrate resistant prostate cancer. Now this the continuum few years ago, maybe up to 1 or 2 years ago. But now we have already subclassified this. Rather than just do on a burden of metastatic disease, we now talk about something else, which is the oligometastatic hormone sensitive prostate cancer, the very early stage of metastatic disease, where there's only few metastases. In fact, now before the oligometastatic disease, there's also now such thing known as a non-metastatic castrate resistant prostate cancer. I'll mention later. When one talks about the possibility or the proposed curative treatment of oligometastatic prostate cancer, that means we are talking about 3 things actually. One is the treatment of the primary tumor itself, that means the prostate. We are going to do a local conservative therapy of the prostate, either by radiotherapy or surgery. Secondly, we talk about metastatic directed therapy. That means we not directing to a primary tumor, but directing to the secondary metastasis. And thirdly is systemic chemohormonal therapy. That means give chemotherapy or hormonal therapy. So when one talks about so-called possible curative treatment, we are talking about 3 things. But our talk today is based on metastatic directed therapy. That means radical treatment of the metastasis. Is there a justification to do so? What does the evidence tell us? And in my part of the debate, is to convince everybody that radical treatment is not justified so far. There is no evidence to it. Now let us look at, before anything, let us look at the basic science. Okay, we talk about circulating tumor cells for metastasis and how small is it, what number that needs to be detected. Now when we have 5 or more circulating cells in each, let's say 7.5 ml of blood is associated with metastatic progression. That one we know. In an individual man who has no detectable metastasis with a CTC count of 5, we'll have at least 4,300 circulating tumor cells. That means with 4,300 circulating tumor cells, we don't have any detectable metastasis. For it to be detectable, the tumor, at least the clump, must be at least 4 millimeters long. So the cancer cell may be about 10 microns in diameter for it to have at least 200 million cells of them before the smallest metastasis become detectable. So it appears to be clear that there is no possibility of cure without systematic treatment. That means if you don't use systemic treatment, how are you going to cure them? Because you have millions of cells circulating. And currently we have no systemic treatments that can cure metastatic prostate cancer on their own itself. Now the same argument comes into play. Now how long does it actually take for prostate cancer to go from first microscopic metastasis to the point where it is detectable metastasis? See, we know very well on average it takes 9 years for biochemically recurrent prostate cancer after radical prostatectomy to the time of first bone metastasis. It takes about 9 years in average. Okay, and that means there are billions of cells in one place. It may take years and years before the next bone metastasis is detected. We also know lymph node metastases are very slowly progressing, and it's not unusual that many years have to pass between new detectable lymph node metastases. In other words, by the time we actually detect metastases, there are a lot of actual small cells, billions of cells, cancer cells around everywhere. And now we know also very well the new PET scans can detect metastases very much earlier. So actually, does it make any difference if you want to detect the metastasis early? Because there are billions of cells around. Are we going to actually achieve cure than what we have already been achieving now? So my question is this. Does it mean by early detection and treatment of metastasis, will it slow the progression and increase survival? That means if we detect these small amounts of metastasis very much earlier, does it make any change? Is it because we are trying to detect something very early, it may lead to a lead time bias? We know very well that choline PET scans can detect metastasis when the PSA is only about 2 nanogram per ml rather than 20 nanogram per ml for a bone scan. In fact, the PSMA PET scan can detect metastasis even with the PSA of 0.5. So how low can you go? The lower you go, does it make any difference actually? Does your treatment actually delay the progression? You may detect it early, you may start treating it. But do the patient lives as long or longer just by detecting these things early? Not necessarily so, because it takes a very long time to detect subsequent metastases later. That's my argument. The other question I pose to everyone is in the evaluation of oligometastatic disease. Now currently, the validated imaging modalities of prostate cancer is nuclear bone scan and CT scan of the abdomen and pelvis, and sometimes we use MRI. PET scans, either choline PET scan, PSMA PET scan, sodium fluoride PET scan, actually not considered standard of care right now, although most people are using PET scans. Because why? They can identify more lesions than the conventional imaging, but when we identify these very small lesions, we're going out of the current literature. Does it make any difference even if we detect it early and treat them early? Optimal imaging currently to determine extent of disease is yet to be determined. We don't have a proper optimal imaging or standard imaging to say that yes, this is the standard that we need to do for metastatic disease. In fact, if you use the lutetium PSMA PET scan and gallium PET scans, you can detect it even more earlier. But does it make any difference? You actually may result in a lead time bias during treatment of the disease itself. The element of lead time bias must be considered for patient outcomes when using more sensitive imaging modalities compared with the standard of care. So just because we are using newer modalities trying to find it early, does early treatment of this early disease detected by newer technologies make any difference finally in the outcomes or not? That's the most important question. Also, there is an unclear role in radical and metastatic directed treatment of oligometastatic prostate cancer currently. Why? Because the bulk of all the studies and the current data on this is actually retrospective. They are not prospective, and so it is subjected to a lot of bias. The effect of local therapy of primary tumor, that is prostate, either by radiotherapy or by surgery, cannot be determined conclusively in patients with oligometastatic disease currently. All the studies on metastatic directed therapy so far has only been very small single institution studies. They lack randomizations, they lack a control group, or there are no consistent treatment, or they all vary. So the current data itself till today is insufficient for determining their effect on oncological outcome, on overall survival, on progression-free survival, and on recurrences. Now one can argue in prostate cancer, the treatment of lymph node diseases actually improves to some amount progression-free survival and overall survival to some amount. Okay, but this is treatment of lymph node disease is not treatment of oligometastatic disease. Lymph node disease is not considered as metastatic disease. It's considered as nodal disease. So in spite of the fact that sometimes we actually remove the entire pelvic lymph node field doing a prophylactic lymph node dissection, what is the evidence of the efficacy is still mixed. Retrospective studies that we have seen so far are notoriously confounded by selection bias. And if somebody implies that, oh, just because pelvic lymph node dissection, we do pelvic lymph node dissection for prostate cancer, so why don't we treat oligometastatic disease? No, we cannot correlate it in this way, because actually lymph node disease is not considered as metastatic disease itself. True metastatic disease is actually implies visceral and bone metastasis in prostate cancer and not lymph node disease. Now when you talk about the spectrum of the continuum of the prostate cancer, now we know very well that we are now define this as various stages. Okay, we talk about newly diagnosed, localized and metastatic disease, recurrent metastatic disease, non-metastatic castrate-resistant prostate cancer, and metastatic castrate-resistant prostate cancer. And recently there have been various trials which showed efficacy of certain medications in these subset groups as well. The latest ones are high volume metastatic disease in cases with newly diagnosed metastatic disease, where abiraterone and docetaxel and now enzalutamide has also shown efficacy. When you talk about non-metastatic castrate-resistant prostate cancer, studies have come out that enzalutamide and apalutamide also can make a difference. Now this is the argument that those who are proponents of oligometastatic disease are saying now, that if we can have drugs in these various categories, why not oligometastatic disease? This is what I meant by the recent advances in treatment of metastatic hormone-sensitive and non-metastatic castrate-resistant prostate cancers. That means we are talking about very early stages of metastatic disease itself. We now have newer drugs in earlier stages of advanced prostate cancer. But will this likely result in a lead time bias in survivals when we treat them early? This is something that we do not know. Now what about the recent advances here now in treatment of metastatic hormone-sensitive or castrate-sensitive prostate cancer? We know that androgen deprivation therapy with docetaxel is a new standard of care for metastatic hormone-sensitive prostate cancer with high disease burden. This is based on JETUC 15, Chartered and Stampede trials. Now the Latitude study in addition showed that addition of abiraterone acetate with prednisolone to androgen deprivation therapy may make a difference as well in high disease burden. The arm G of the Stampede trial also stated that adding abiraterone acetate and prednisolone to standard long-term androgen deprivation therapy in men with high-risk prostate cancer with metastatic hormone-sensitive prostate cancer actually will make a difference in survivals. Now this is what I meant, the same things, Stampede trials, and when we look here, we have got a Titan trial as well. Okay, and there are ongoing randomized trials for metastatic hormone-sensitive prostate cancer. They include the Arasens trial, the Peace-1 trial, and various other trials on hormone-sensitive high-risk prostate cancer. What about the recent advances in treatment of non-metastatic castrate-resistant prostate cancer? Non-metastatic castrate-resistant prostate cancer means the PSA starts rising. After you treat the prostate cancer, the PSA starts rising significantly enough, with probably a PSA doubling time of less than 10 months, but we cannot detect the bone metastasis through the current imaging protocol. Now it has been shown based on the Prosper trial and the Spartan trial, when they are given medication like enzalutamide and apalutamide, that actually makes a difference in survival rates. In other words, the argument here is you treat these patients early in non-metastatic castrate-resistant prostate cancer, it makes a difference. But we do not know whether that is based on a lead time bias in the treatment or not. Now what about studies on radical and metastatic directed therapy itself? Now what I was mentioning just before, the few slides before this, was based on based on metastatic hormone-sensitive prostate cancer and based on non-metastatic castration-resistant prostate cancers. Now, what about oligometastatic prostate cancers itself? Now, this one study by the Italian group is a single institution study which assessed the long-term outcome in a very small group of patients with oligometastatic disease treated with radical prostatectomy. In other words, this patient had metastatic prostate cancer, low volume metastases. They did a radical prostatectomy, and they found out that to a certain extent, there was a 7-year clinical progression-free and cancer-specific mortality-free survivals of 45% and 82% respectively. However, this study, although demonstrates some select oncological benefit in patient metastatic cancer, it lacks a control group. It is not with a control group. It is not a randomized control trial, and they did not mention of the morbidity of this procedure. Now, this is an interesting study by a Korean group. They were investigating whether radiotherapy of primary tumor in prostate cancer benefits patients with distant metastatic at incisional diagnosis. Very interesting. They was published in 2016 in PLOS ONE, and they apparently made a conclusion that radiotherapy of primary tumor was associated with improved overall survivals and progression-free survival in metastatic prostate cancer. And they said there's a warrant that it warrants a prospective controlled clinical trial with this approach. However, this is based on a retrospective and cohort study and is mostly notoriously confounded by selection bias. Only an RCT can prove that if there's any such benefit. If I'm not wrong, I believe there's a Stampede trial which showed that radiotherapy to the primary tumor actually makes a difference in survival rates in patients with oligometastatic disease. Now, this is another interesting article. Just because it's there, do we have to catch them all? You know, in the world of metastatic prostate cancer, there's considerable interest for aggressive approaches. So, just because they are metastatic disease, do we have to catch everything? Murphy and colleagues are not suggesting that there's enthusiasm to treat such patients effectively by using treatment, but rather, what are we supposed to do? Are we supposed to be like the Pokemon and try to catch everything that we see? Not necessarily true. We have to look at the clinical significance of trying to find out early metastasis and whether it makes a difference or not. Just by trying to detect very, very early metastatic disease, my question is this: if we detect it, does such treatment really extend patient survival? Does it improve quality of life? Very important. We go radical and do radical treatment. Does it actually improve quality of life over time? Are there definable subsets of patients who seem to do better than others? Is there a specific form of imaging technique that we should use to call it a gold standard? Because currently we don't have a proper gold standard to say that, oh, this is the imaging that's gold standard for currently. Currently bone scan and CT scans and PSA and all that, we can use it as a surrogate to see for metastasis. But what's the actual gold standard? Is PET scans a gold standard now? Those are the questions that can be posed. Many clinicians are making unsubstantiated claims of cancer control for treatment of oligometastatic disease of prostate cancer, which is those with less than 5 detectable metastases. But only a randomized clinical trial, only an RCT can prove there's any benefit of such treatment. I believe Johns Hopkins has announced the first such RCT is known as the Oriole trial. We have to wait for a number of years before this outcome is published. As you can see here, these are the many different trials that are undergoing now. Many are still recruiting. Trial results be out in maybe 2022, 2024. We have to wait and see what are the trial results and whether metastatic directed therapy in oligometastatic prostate cancer makes a difference or not. We have to look forward to the outcomes of these specific RCTs, which have longer follow-up of more than 6 months. They mainly include the core RCT trial at the Royal Marsden Hospital, which is expected to complete in 2021, the STOMP RCT trial, the PCX9 RCT trial, the French RCT trial, of which the study will be only completed in the trombone trial, and the GRAM trial, which actually planned report date is at 2025. So to me, we have many uncertain issues in oligometastatic disease as far as prostate cancer is concerned. How do we define disease burden? What do you mean by oligometastatic disease? Less than 3? Less than 5? Is it visceral? Is it bony? If we think there's a treatment that is available that can make a difference, what type of treatment is it? Is this a consolidative treatment of the primary tumor? Or is it a metastatic directed therapy? What level of disease burden should we actually treat? And what level should we just not treat? We know very well that prostate cancer screening itself is a very controversial topic, and whether to treat an early localized disease makes a difference or not. So in metastatic disease, what level of disease burden should we treat? Disease burden is very small, where the patient is expected to wait another 9 years or 12 years before the disease burden gets high. If we do so, which type of systemic treatment should we choose? And how do we sequence the treatments? And what's the appropriate endpoint to select when treating patients in this context? All these are uncertain issues. So the conclusion to me now is there are no prospective randomized data to show a benefit of ablative therapy in the metastatic lesion in oligometastatic prostate cancer, whether it's a primary either with or without systemic therapy. Furthermore, newer drugs in earlier stages of advanced disease are becoming more available now. So we do not know whether in future we will have these drugs available. But even if these drugs were available, will it actually make a difference, or is it just a lead time bias in survivals? There are many ongoing prospective clinical trials, and that should at least provide us with some data over the next 5 years or so. Currently, to me, aggressive treatment of oligometastatic prostate cancer should only be considered only in the setting of a clinical trial or registry, and the patient should be informed of the limited evidence of benefit from such. I won't go into this very complicated slide. It just states the different types of treatment that has been proposed, or what should be in clinical trials, whether you do a radical prostatectomy or you do a salvage lymph node dissection or stereotactic metastatic directed radiotherapy. So take home message is quite clear. Management of advanced prostate cancer represents a definite oncological burden. We should strictly stick to the current known treatment guidelines and the gold standard of practice. Androgen deprivation therapy is a cornerstone of the management of metastatic disease, and then followed by chemotherapy and now targeted agents. Oligometastatic prostate cancer is actually a new terminology, very undefined, and we should wait for clinical trials to find out exactly does it make any difference in treating or even in diagnosing and treating oligometastatic prostate cancer, and does it make any difference at all? So my presentation today is on a debate on the arguments against radical treatment in oligometastatic prostate cancer. What is meant by oligometastatic prostate cancer? That means it's a very low burden prostate metastasis. In other words, very few deposits of metastasis in prostate cancer, diagnosed very early. Do we have to diagnose it in the first place? What imaging modality we need to diagnose? Even if we diagnose it early, does it make a difference in survival rates? Just because we treat it early, are we going to change the survival rates in the natural history of progression of metastatic disease? Those are questions that still has been unanswered yet. Probably we have to wait for another few years for all the randomized controlled trials to be finally published, and then only then we can know the actual answer. I hope this presentation has been useful. I am Dr. Rajeentheran Suntheralingam. I am the consultant urologist, and thank you. I hope you found this presentation interesting. Thank you.